Okay, I think it is now time for questions and discussion. So I will turn it over to Shantala for a question and answer time. Shantala is one of my IP colleagues. Go ahead, Shantala.
Thank you, Barbara. Let me pass it on to Erin, and then I'll take it back. Erin?
Sure. I just wanted to welcome folks to leave any questions or comments in the chat. And then if you wanted to come off mute, go ahead and raise your hand so we can see you and make sure that we get you off mute. Again, thank you, Barbara and Sheila, for sharing all of this information with us today. We did leave a bunch of links in the chat, but you'll have access to all of that via the Train the Trainer website where you registered for today's training. So do bookmark that page so that you can access the toolkit and all of the materials you saw shared today. All right, so I do see one question in the chat, Shantala, so I'll go ahead and turn it over back to the IP team. Thank you.
Thank you, Erin. Before I answer the recent question, there is one question in the beginning of the session. I will start with that with Sheila. Sheila, this was a question from one of the facility. They don't have any barriers, but they were not sure how to do the assessment for ESP and to place them in an isolation. If you can give them how to do the assessment and ESP versus isolation.
Yes, thank you. So before I start, I want to clarify that ESP is not isolation. It's an approach on how SNPs can reduce the spread or transmission of germs or organisms. So the way you can assess your residents is to see if they have any devices, such as a central line, a urinary catheter, and a tray. So those are one of the risk factors, and also wounds. Any wounds that are not healing, that have drainage, those would be the two criteria to use ESP with your resident during those 6 high contact activities that were mentioned in the 6 moments. So it starts again, the assessment starts with looking if they have devices or wounds, and then you then ask yourself, what activities will I be doing? If it's one of those that are mentioned in the 6 moments, then you would also use your gowns and gloves.
Thank you, Sheila. Again, I think is next question for you, Barbara. The question was, is it a mandatory requirement? Is ESP mandatory, or if not, what is the consequence if they're not following it?
So AFL 22.21 specifies that ESP is recommended by the California Department of Public Health. Now, I understand the word recommended. However, what is a requirement and that we should all consider is MDRO transmission must be addressed by your facility. So you are required to stop MDRO transmission in your facility. CDPH is recommending the practice of using ESP as a way to fulfill this requirement. But as infection preventionists, I feel like we can all agree that MDRO transmission is, of course, the highest priority. And so CDPH recommending ESP and saying that using this toolkit in a systematic way is going to help you based on the data that we have, makes it a very strong statement in favor of implementation of ESP.
Thank you, Barbara. Next question for you, Sheila. If you can go over the difference between, yes, you have a risk factors for with the device and then the wound for who meets the criteria for ESP, but how it can help the anybody who's colonized with the MDRO, how you can transition them to a better resident-centered care with the help of ESP.
Okay, so as I mentioned with the last question, we wanted to establish the criteria, and the criteria, ESP is actually very helpful for us to handle patients with unknown MDRO status, because many do have MDRO we may not be aware of. So that's why we truly focus on those criteria of having an indwelling device or wounds. And what was the second part of the question, Shantala?
The question is how they can transition the resident from a transmission-based precaution to ESP, how it's going to help them with more access to socialization or activities.
Okay, so for transitioning from contact precautions or transmission-based precautions, it is going to depend on a few things. One is what MDRO we're talking about. If it's those that, such as carbapenem-resistant organisms or CRS that are of high concern right now, that might be a slower process versus MRSA, VRE, those that are prevalent in a lot of communities already. So we would advise you to work with your public health. First and foremost, your facility could not be in an outbreak at that time. We would have to make sure that has been reviewed and made sure that you are not in an outbreak or you're already coming out of an outbreak. And then you'd want to discuss with your local public health as to if the prevalence of that organism in your community and how you would approach transitioning them from contact to ESP.
Thank you, Sheila. Barbara, this question for you on a PPE placement. If you can go over where do they need to place the PPE?
Yes, so PPE placement should be convenient for your staff. So in the guidance, CDPH is purposefully non-prescriptive on where to place that, because we recognize that each facility is laid out so differently with different cabinets and locations available. So we suggest highly, though, that it is convenient for your staff so that they can access it, not having to go too far out of their way.
Thank you, Barbara. So second full question for you, Barbara. So can we transition CRE and CRS from contact isolation to ESP? Sheila covered it, but go ahead.
Yeah, so great question. I would highly recommend page 5 of the document we referenced on the in the toolkit on enhanced standard precautions. So page 5 of that document addresses this. And like Sheila said, what you're going to do is, if you're not in an outbreak situation, then you can consider using ESP for residents with Foley's or central lines or ventilators with an indwelling device or wounds, and use ESP on these residents. So, however, if there is an outbreak of a specific organism like C. auris or CRE, then you're going to not use ESP and put those patients on contact isolation. And then you're also going to want to consult with your local public health department about the prevalence of these organisms in your county. So again, we're deliberately not being prescriptive because the situation in each county is different and each facility is different. And we're wanting to move to a risk-based approach with this.
Thank you, Barbara. Sheila, this question for you. Do you recommend ESP practice for history of MDRO patients who's asymptomatic, or apply practice for all patients with 6 moments?
Okay, so again, this is not based on whether there's your patient, your resident is asymptomatic or not. It's more, or even if you know the MDRO or not, it's more based on those criteria. And so it still ties in on the past couple of questions. I wanted to mention that another thing that should be considered is your own facility. How well are they implementing ESP? Are they very comfortable with it? Is your adherence monitoring showing that your staff has a good grasp of ESP? Or is your cleaning adequate? And those type of activities that that involve ESP before you start wanting to transition individuals from contact precautions to ESP because they no longer have, you know, symptoms and so on. You want to make sure your ESP adherence is strong.
Thank you, Sheila. Barbara, this question for you is, if a patient has been in the facility for over 10 years and has G-tube, so we would now need to put them on ESP.
So that would meet one of the requirements during implementation. And I get kind of the undertone here. One of the ways to approach this with our staff and our residents is to say, you know, with the onset of the COVID-19 pandemic, we've seen an increase in MDROs. We've also seen that not all MDROs are recognized on admission. So healthcare changes and the environment in which we practice healthcare has changed. Thus, we need to use additional precautions for patient safety. Again, making sure that the resident knows that this is going to help them be safe from acquisition of a new pathogen.
Thank you, Barbara. Deviating from MDROs, we'll come back. There are a couple of questions. Sheila, can you go over any special handling on linen, trash, and do they need to have any disposable trays if the resident is on ESP, please?
Yes. So the linen, the trash, and any plates or anything from the dietary do not have any special treatment. So you don't need 2 bins of trash and so on. Everything goes in the same linen, same trash, to the kitchen the way it does for all the other patients. The processes that we have in place already to clean and disinfect those items are sufficient enough for patients that we are using, have an ESP. Thanks for the question.
Thank you, Sheila. I think to add to what Sheila mentioned, so there was from last 3 previous sessions, there was a question regarding whether do they need to have a separate linen basket or the laundry basket inside the room for if they have a ESP resident, sharing the room with a non-ESP resident. No, there is no separate linen barrel is required. Barbara, this is a twofold question. I think it may need all 3 of us to jump in to answer, but let me start with you. Would a resident with the MDRO but area is not contained, such as catheter or a wound, but with a dressing, be a candidate with ESP? I'll start with that question.
Okay. So depending on some of the things that we've talked about, so it depends on what kind of MDRO we're talking about, and the facility history with that MDRO as well as the county history with that MDRO. So obviously CRS is going to be handled differently than MRSA. So assuming it's maybe an MRSA, VRE, ESBL, then and we're saying that the drainage is contained. I think there's a correction in the chat about if it's contained. If the drainage is contained, then we would consider that a candidate for ESP, providing again that the pathogen is not novel to either the county or to the facility, and that there are appropriate, what Sheila was referring to, horizontal measures of infection control in place, meaning good measures of hand hygiene, appropriate disinfection by environmental services, and so on. Then you're a candidate for transitioning that resident because of the contained wound to ESP.
Thank you, Barbara. Sheila, is there anything you want to add?
No, I think Barbara covered it pretty well.
Thank you. I think there is a difference. There is a next question we have is when the drainage is not contained in resident, why is it that precaution is contact precaution only and not enhanced standard precaution? We are also talking about when we are talking about the contact precaution, as Barbara and Sheila mentioned. So you also need to think about, is it an active infection? If the resident isn't having an active infection, that usually they're on antibiotics. You had to look at the signs and symptoms, and then they will be in a contact precaution. If the drainage, it is contained, so then you are looking at that is enhanced standard precaution. You can place that resident in an enhanced standard precaution. But if there is a case-by-case scenario, you may have to review. Sometimes the drainage is so much that they cannot. It's very hard to contain. So there was a question came up yesterday on a wound vac. If they have wound vac, it is usually contained. So we are going to respond to that in our FAQs, all of these questions, if we are not able to answer it here today. The next question I have for you, Barbara, is how long do we have to put a patient with CRE diagnosis admitted someday? Resident is asymptomatic. Can we have this patient be in a shade room? So it's a cohorting question they're looking at for CRE.
Yeah. So again, talking with your local public health to see the status of CRE in your county and your facility is first where we would start. Looking to see if the facility is currently in outbreak with CRE would also, like I said, be a consideration in this very much. And then once all of that is determined to be positive, CRE transmission has been halted in the facility if ever there was evidence of such, and the local public health has said, no, this is not novel. Then you can consider the resident for ESP based on the criteria we've talked about, indwelling device and presence of a wound. And then residents can be cohorted on ESP, because remember, we're considering all residents on standard precautions. So anybody in the room would be on standard precautions, and then you would have residents identified as needing ESP would be on that as well.
Thank you, Barbara. Again, as Barbara, she re-emphasized several times, work with your local public health to make sure your cohorting practice meets their guidance. Each county may have a different guidance on that. The next question, I don't see, Erin, do you see anybody hands up?
I don't. Thank you.
Thank you, Erin. So Sheila, the next question I have for you is do they need any physician order to place a resident on ESP?
Okay, so ESP is not isolation. So my quick response is to say a physician order is not required, although what you do need is a policy that specifies the process that you are, since you'll be implementing ESP, the process that you'll be taking to identify which residents are on ESP, including, the criteria and those 6 moments. And I would advise to still take it to your leadership and your medical staff to determine if they will ask that to be part of the policy that an order is required. But just remember that, this is not isolation. It's not transmission-based precautions. It is a process or an approach that just requires the use of PPE for certain activities. So just keep that in mind when you're determining that for your facility.
Thank you, Sheila. Based upon last 3 sessions, there are facilities who have already implemented. In yesterday's session, there was almost few facilities have implemented for more than a year for now. And they did get some physician orders, as well as they have used it in the care plan. As Sheila mentioned, make sure you get your medical director approval on the process to ensure. Barbara, next question. I think there is a comment. Is there a decision tree to help guide these decisions for infections and precautions? That's a very good question. We do have a cohorting tree, a decision-making tree. That's something which we can, we have some guidance. I think, Barbara, we can come up with a guidance to help the IPs.
I agree. Yeah.
Thank you for the suggestion.
Yeah.
And I think I don't see any other question. If anybody else has any, please feel free to come out to mute and ask questions.
I think it's a quiet group. It's Friday afternoon.
That looks like it. I think it's again, so this is more of how we are supporting you or helping you to provide training to your staff, right? How to be a trainer. So again, it's many of you you may have already read the document, but it's still confusing for many of you. What is a standard precaution? What is enhanced precaution? What is a transmission-based precaution? What is all this? We just came out of COVID. There's a lot of this confusion will come up. Please feel free to reach out to the email contact what you're going to receive. And if there is any questions, we can answer you. Our recommendation is always go through the document first. You understand the concept and reach out. So with that, I will pass it on to Erin.
Sounds good. Thank you all for your questions today. Again, feel free to reach out. We hope that this can be a resource for you, a community for you. So you can reach out to, anyone at the HAI program or the HSAG or each other even. We hope that you'll make some friends and get to know each other and really work through this together.